Hi, I'm Keisha Shepard with Maryland Progressive Healthcare Coalition. Welcome to our webinar on America's dual epidemics, healthcare, racism, and COVID-19. Thank you so much for joining us. We have an excellent panel of speakers today, and we're going to be discussing all of their experiences as well. And after that, if you have any questions, just go ahead and put them in the chat. And after each of the speakers has spoken, we are going to um, let you go ahead and answer. We're going to answer your questions. So also, let me go ahead and get started with the speaker bios, which actually I'm going to go ahead and just let the speakers introduce themselves. I'll start with Walla Blege. Walla, would you introduce yourself, please?
Yes, I am Walla Blagay. I'm an attorney. I'm counsel for have Massa Consulting, the People's Advocate LLC, but I'm also counsel for the DC Nurses Association. Should we go into some of the things we're going to discuss today, or is this just a
Yeah,
brief
sure.
discussion? Okay. And just kind of opening up the discussion, I want to just start with the reasons why, when we talk about health disparities and COVID, and just about how it impacts Medicare for all, we realize that the health disparities is not alone just about just the healthcare providers and just the ways when we talk about like health and what how people live, but just how we actually going to talk today about how the actual service, the actual health insurance, how that impacts healthcare disparities. And so one of the first big question that people ask is, what is the healthcare disparities? What are the healthcare disparities? The reality is Black and Brown communities have higher rates of health concerns than those in the white community. And
Yeah.
so we kind of can go over, and I pulled up some numbers through the Centers of American Progress that kind of highlight some of the concerns that we have, and then I can go into how the healthcare insurance process that we have now, how it exacerbates this problem. So right now, they said that 90% of African Americans have healthcare coverage, and this is 2017, compared to almost 95% for white Americans. So we're talking about just just healthcare and coverage overall. We still have uninsured coverage in the African American community, and 44% of the African American community has government health insurance. And the way the process works now, we could talk about how that also impacts health disparities. And when it comes to chronic health conditions, they say 12% of African American children had asthma compared to 7% in the non-Hispanic white children. For African Americans, 42% of African Americans over the age of 20 suffer from hypertension, and this is compared to around 28% and for those in the white community. Mental health is another problem. Only like they say, 9% of African Americans have received any mental health services compared to almost 20% in the white community. The leading cause of death in African American community is heart disease, cancer. And we have higher mortality rates when it comes to all cancers. For infant deaths, we at a higher rate. Infant mortality rate is almost twice the national average. And when it comes to the Hispanic community, Latinx, we're talking about 16% uninsured compared to 5%. And 6% in white communities. And also the fact that they say around 40% have government health insurance coverage. So that's something I'm going to touch on today, why that matters. Those in the Black and Brown communities tend to have a higher rate of health insurance coverage in the Medicare, Medicaid system. Chronic health diseases in the Hispanic community, they say 21% of adults over the age of 20 have diabetes compared to 13 in the white community. 25% of Hispanics have higher blood pressure. Hispanic women are more likely to have cervical cancer. And even mental health services, like only 8% of Hispanic adults are getting that. Their leading cause of death is cancer, heart disease. Infant mortality rate is higher. So we're talking about, these are just some of the big, just to touch on just what is the health disparities. Those are just, I just touched on a smaller number. When we had the COVID, we talked about how in African American community, Hispanic communities, we have a higher rate of infection and a higher rate of death. And this is also because of the high, some of the numbers that I just gave, the underlying health conditions in those communities. So we go into, how does the health insurance impact this? And I wanted to just, focus in on the fact that in the service, the model, payment model in the United States right now, because we do not have a single payer, a Medicare for all system, is fee for service. And fee for service basically allows a health insurance to go to a hospital and say, okay, I'm going to negotiate that a knee surgery is going to cost this, a heart surgery is going to cost this, a doctor visit is going to cost this. And what happens in most states for fee for service, because most states have the fee for service model, is that the insurance company, first of all, there's a part of this that they talked about. There's no incentive to improve the healthcare of the patient because it's a fee for service. So every time you give service, you get paid. So there's an incentive to drive the patient back into the hospital, which of course increases the movement in the hospital, but also increases the funding for the hospitals. But also the insurance companies are able to negotiate based on the hospital what they pay. So, this benefits, and we talked about this. I looked into this and studied this when I was working on the issue in Southeast with United Medical Center. The reality is that in DC as a model of this, where Georgetown can get paid if, let's just say, let's just say a procedure is $5,000. If they, the insurance company will go to someone like Georgetown or GW or even Johns Hopkins, and they're going to say, well, we have better outcomes, we have a name, everyone wants to come to us, we expect that you're going to give us $4,900 for this. And, because of their name, they're more likely going to get it. A Howard is going to come and say, well, we want 49, but the insurance company will say, no, we're only going to pay you 2,000. So that's what you have to take. And then a hospital, the hospitals in low income areas like United Medical Center get the short end, where they don't have that ability to say, this is what we have, this is why we need to get paid. So they get paid what they get paid. And so that's the system in most of the country that we have. And that is the reason why we do get the process that we have now, whereas, you get like in low income areas, most of those hospitals are not surviving. We see that across the country. That's a big concern. One of the things is that almost in most of those hospitals, they call it community-based hospitals, they don't have the ability to really negotiate high rates from insurance companies. So insurance companies pay them lower, and Medicare, Medicaid does not really negotiate. They pay what they pay. And so because of that, now we talked about in the African and Black and Brown communities, African American and Hispanics, we're talking about a payment model where 44% in both communities are both on government health insurance. So that means that anybody who cares for them gets paid the lowest right now, because Medicaid and Medicare is the lowest payer. And so those that service them don't have the resources for the best care. So you're talking about areas like Southeast DC, and of course there's a different payment model in Maryland, where they have an all-payer model, and that's supposed to be a better model. It's not perfect, but it definitely provides a better than fee-for-service, where the state sets the rate. So it does limit the insurance company from saying this hospital gets this hospital get that, and because of that, that does kind of equalize the payments over the across. But because of the high increase in health insurance, in health costs, they have had to actually put a global health budget together to fit that. And over time, how sustainable is this if the cost keeps rising? Which there's other push behind that, why it keeps rising. So, just kind of going into that, they have the value-based service, which is another way that hospitals are paid. And in that service and in that model, that they say that that's an incentive for better outcomes for patients, but it also encourages hospitals to look into becoming the the expert on heart disease, the expert in this, and that is becomes a driver into bringing more people because they have better outcomes in that. But if you're in an area where you have those who have those chronic health conditions and poor in areas that they don't have the doctor that they're constantly going to, you're not going to get those outcomes that some areas where they don't have those with the chronic health diseases. So value based does not even give, does not, it's not the equalizer. It does not provide that if you're in an area where those that have higher heart disease, higher hypertension, their outcomes are not going to look like those that don't have those. So you're not going to get the value, the payments that you want. So right now, like when we look at the way our process, our whole system works, Medicare for All does kind of remove that insurance company being able to negotiate whatever they want and how they want to be paid does create a process where hospitals with more with more money, with better endowments, they have all the things behind them, are able to thrive better with this insurance, their insurance kind of playing this game. Whereas if you're in a low income area that doesn't have those things, you are going to suffer and have less resources to provide the proper care. And let's not even go, the small part I didn't talk about is just our doctors. Doctors in general in certain areas and low income areas are not able to sort of have thriving practices because they have to take mostly Medicare, Medicaid patients. They get paid at a lower rate. And the insurance companies are not willing to give them the highest rates and pay them the highest rates because they have the negotiating power. And they're not going to do that if they don't have to. So we're at a place now that we have the insurance model, payment model is encouraging health disparities. It's encouraging health disparities because those in certain areas have doctors that cannot get properly paid because they have to just do Medicare, Medicaid, and there's no push when you're comparing when insurance companies compete with Medicare and Medicaid, they're going to win because they have more power and the government is limited. There's no incentive right now to even improve the Medicare Medicaid system because at the end of the day, the insurance companies play a bigger role in the payment model. So it definitely need to talk about equalizing this process.
Thank you, Walla. That was awesome. Thank you for all of that information. Let's jump to Adrian. If you would like to introduce yourself and give start talking about your speech.
Oh, she's muted.
Yes, Adrian, you're muted right now.
Thank you for inviting me to participate in this. I think this is really important for us to have a dialogue and to begin to imagine what healthcare would look like for all of us if we all had equal access and we all had the best outcomes, regardless of what chronic illness or disease we had. And to also look at what we can each do, the power that we have to change our own lives and make our own healthy choices. But as a family practice trained physician who's been seeing patients for over 20 years, I've had the opportunity to serve patients in a variety of settings, from the DC Department of Health to the Indian Health Service on Indian reservations, military bases, federally qualified healthcare clinics, as well as larger corporate urgent care centers. And across all of those platforms, I've seen the disparities where you can see patients that don't have the best insurance will come in and make urgent care their primary care, whereas patients with better insurance will come in for a sore throat or a cough, but for their primary care, they have a primary care provider for their long-term care, someone who knows them, knows their families, and who is an advocate for them. Whereas in other platforms, patients don't have that given to them. But I don't want to take up a lot of time with my introduction. I want to thank you again for inviting me to speak. I look forward to the conversation that we'll all have together and to answering questions.
Thank you. Sergio, would you like to go ahead and introduce yourself as well?
Sure, just a quick introduction. My name is Sergio Spania. I'm the Director of Engagement Mobilization for the ACLU of Maryland. Before that, I've been doing organizing in a variety of different ways. One of which that I'm the most proud of is working with folks, including some people who are on this call, on working with people across the state to launch the the Healthcare is a Human Right campaign in Maryland. It's been an active effort working with y'all to establish a universal healthcare system in Maryland and to support broader single payer efforts nationally. Yeah, I'll be talking a little bit about the impact of our explicitly racist healthcare system in society in the Latinx community, and how we're coping during COVID.
Thank you. And Dr. America, would you like to go ahead and introduce yourself?
Yeah, hi everyone. My name is Dr. Sanjeev Sriram. I am also Dr. America for WEAC Radio and ACT TV. I am a practicing pediatrician in Southeast Washington, D.C., and I live in the great state of Maryland. And Keisha, do I have a minute to just kind of go over the legislation that we'll be talking about today so that we all can kind of just sort of know what we're talking about, the same thing?
Yeah, let's wait to do that until you can do it while you're speaking later.
Okay, that sounds good.
That sounds good. I'd like to just jump right back into Dr. Charles so that she can go ahead and give her experiences and let us know more about what she's seen during this pandemic with COVID and racism.
I've seen patients come in who are afraid that because of COVID, they will be treated differently, that they are not comfortable sharing when walking to the front door, that they have been exposed. They are afraid of being shunned and not being treated. I'm seeing patients that are working in the food industry, our Latinx patients who are exposed by and large, working in the food industry and living in multi-generational housing, who are at very high risk. I'm looking at patients who come in for minor problems, but as you begin to delve deeper in the hospital or clinic visit, you're finding out about long-term chronic illnesses. People are being diagnosed in the hospital. They are with diabetes. They're having dizziness, nausea, vomiting, going to the emergency room, and that's how they find out that they have diabetes, and then they come after they've been discharged. So there's been no healthcare throughout their adult life. And now they're in their 30s and they're finding out that they have diabetes that's uncontrolled. And now they're trying to find out how they make themselves better. What do they do? I'm seeing patients that are repeatedly getting refills on medications because they don't have time to come in. They're working several jobs, so they call in and get their meds refilled, but they haven't been seen and their blood pressure hasn't been checked. And the blood pressure medication it needs to be adjusted sometimes, but because they're calling in, that hasn't been done. I'm seeing a lot of patients falling through the cracks because of COVID. They can't get into their primary care doctor. The office is closed. They're only taking phone calls. So then they come to urgent care or to the emergency room. And this is where things can get missed, because in urgent care and emergency room, certainly in the emergency room, it's about an emergency. Are you at risk of dying imminently? And once that is determined, no, you're not dying. You can go home, go see your doctor. But people are coming, it's an emergency to the individual who's coming there, but not from the perspective of the emergency room doctor. And in the urgent care center, you have to see X amount of patients in an hour because it's a steady stream of patients, and you can't give a patient half hour, 45 minutes. You have X amount of time to address as many problems as you can in that time frame. So doctors are not fulfilled because they know that they want to do more. The patients are not fulfilled in that visit because they come with a higher expectation than the system will allow. And those are the kinds of things that we need to work on and address.
Yeah, that is astonishing. I did not know that so many patients were falling through the cracks like that, and the experience of just the average person trying to come into your facilities. Let's move on. We're gonna have Sergio go next. Sergio, would you like to introduce yourself? I mean, go ahead and speak on your topic with the Latin community, Hispanic.
Sure. First, I just really appreciate what folks have shared so far. Doctor, I lived that out personally this week with my grandmother, who was trying to get a treatment. I won't go into details, but was trying to get a treatment for weeks, and they wouldn't allow her until she first got COVID tested, then got approved, then went in, even though, I mean, I just came back from the hospital with her, and it's very clear she needed to be seen much earlier. And frankly, it's I know for a fact that it's going to make an impact on her outcomes. And so we actually ended up going to the emergency room and just having to, stay there until they were able to do the procedure for us to get the news, and we're now working on how to move forward. But it just shows just how definitely people are falling through the cracks as a result of COVID, to say nothing of COVID itself, which, it's after 6 months, I know for a fact we're not getting numb to it, but it's so overwhelming that it's just harder and harder to fathom. But we are at over 200,000 recorded deaths. The number is much higher, and as we all know, I don't think we need a webinar. We've either lived it personally or we've seen it in the news that the people who are overrepresented in illnesses and deaths are people from the Black, Hispanic, Latinx, and working class communities. And that has nothing to do with our genetics, and has everything to do with living within an explicitly racist country. That we need to, I'm very, very grateful for the moment that we're in, as horrible as it is, because we're seeing also just how much people across the country are realizing that we need to take on the explicit white supremacy in our country head on, if we're going to have the systems in place to ensure that we have healthcare coverage for everyone. One of the saddest insights that stuck with me in working on pushing for universal healthcare over the years was this point that was made in a town hall that really struck with me, where it was a professor talking about how obviously we need single payer. The majority of the country is in favor for it. In 2020, it's even higher, the number of people that are behind it. But until we actually have some sort of acknowledgement of the the racist practices, the racist past, the racist present in our healthcare system and more broadly, we're never going to take it on, because fundamentally we live in a society that doesn't see us all as equally worthy. And so we, as a result, we have a healthcare system that reflects that. It's simply a reflection of our culture and our society, where we're supposed to be thinking that, well, if you make a certain amount of money, then you deserve a certain amount of care. If you live in a certain neighborhood, you should have a certain level of coverage, and so on. And we are seeing that in a way that isn't just overrepresentation in deaths within the Latinx community, but just as a country, we're seeing the consequences of that. When we have a system that keeps saying that it's all about the individual and then everyone needs to pull themselves up, and we need to make sure that we spend twice as much in healthcare as any other country while still having 30 million people uninsured, we get the horrifying death toll that we have right now as a result of COVID, where we just have a completely disparate, broken system without a plan, intentionally so, because where there's this type of chaos, there's opportunity for folks that not in the medical profession, but in the bureaucratic profession, middle people, to profit off of it. In the Latinx community, obviously, and while I was talking about this earlier, that we've been struggling for years in this, where we've been, even though the Latinx community tends to actually be overrepresented in terms of workforce participation, we're underrepresented in terms of health insurance coverage, because really mostly because of folks that are in the service sector, or because of their immigrant status, which makes it harder to find the kinds of employment that would provide robust healthcare with benefits, or will provide limitations to the kind of health coverage that immigrants can get, even though they're paying taxes into the system, regardless of their immigration status. And since COVID, we've seen that, and not just since COVID, since the Trump administration, we've seen that only get higher, as it's been, the number of Latino children who have been uninsured has gone up in the last couple of years by a percentage point. It seems like, at least look from the studies I was looking at earlier this week, every other year. And we're also seeing that the number of just the number of cases, like in Baltimore City where I live, the majority of cases are actually in the Hispanic community, despite, we're living in a majority African American city, to give you a sense for just how much, folks in our communities are being put at risk. But I think it's important for us to keep in mind that how we improve outcomes in the Latinx community, and in the Black community, and the white community, the Asian community, the broader country, is by needing to talk explicitly about around how to see each other's humanity, and how that a single payer system, a universal healthcare system, I think it's a way that allows us to have that conversation as well, in terms of why we need to move towards it. It's because it's about recognizing that if we're not investing in each other on the fundamentals with the same level of compassion and access and resources, we all fail. And suffering is going to go up across the board, which is what we're seeing in the country right now. And would also encourage us to continue to point out within your community, as you're seeing, to really be asking how who's following COVID guidelines and who's pushing against it. And what we're seeing is that I just found out today that Britain is thinking about completely locking down again, and they have, I think we have like almost they have about a third of the number of cases that we've got in Maryland, and they're going for a complete lockdown. Meanwhile, in Maryland, we're continuing to push to open up. And why is that? because of the fact that so many business owners want to keep making money, and so many politicians think that it's dangerous to give the impression that all of our tax dollars can go to directly benefit us. And so rather than going this route of pushing for expanded healthcare access, expanded resources to make sure that people have roofs over their heads, instead we're in a society and a system, both at a healthcare level and more broadly, that doesn't want to risk us recognizing how much power we have and how much how our tax dollars are meant to work for us, not just to be used to siphon off funds. And so I think it's important for us to really be talking explicitly about that, and to push back against the sense of opening, because as we keep doing that right now, we're only going to see numbers increase over the next couple of months. And the people that are going to be impacted the most are frontline workers, low wage workers, and the Black and Latinx community in particular.
Thank you. I was taking so many notes while you were speaking. There's so many things that just you brought to light for me. I'd like to move on to Walla and let her have a few minutes to speak as well. You're on mute.
I made a lot of comments at the beginning, kind of got confused. I thought we were talking a little bit about what we were going to, discuss here. Just to reiterate some of the, I did kind of mention since we're talking about health disparities, but just really focusing on the fact that, in the numbers that I gave, we have a lot of people in the Latinx community and African-American community who are on Medicare and Medicaid. The reality is that many people assume that with Medicare for All, we're going to just put everybody on there and kind of keep Medicare and Medicaid the way it is. But as people need to understand is that the actual involvement of health insurance is what makes Medicare and Medicaid weak. It is what makes it, it gets to the point where it does not provide the care that one who has it needs. So you find that now the biggest frustration for those, especially those on Medicare, is that what it doesn't cover, what doctors don't take it, what prescriptions are not covered, that they have to come out of their pockets. And then you have, and of course, part of the, when I was looking at the numbers, they said 12% of African Americans under the age of 65 have no health insurance coverage. And then they even said in the Latinx community, it's around the same. And we're looking at maybe, and let me just get the actual number, that we have those that are uninsured. So you're looking about 20% in the Latinx community that does not have health insurance. So what we're talking about is a lot of people, when you don't have a health insurance, you don't go to your doctor, you don't make constant doctor visits, you don't have a relationship with any healthcare provider, and the emergency room becomes your doctor. So you have somebody like Dr. Charles that is going to be required to figure out what's going on with you, because you don't have anybody who is able to catch any of the problems or preventative function. So preventative care that should have been provided all along that should keep you from the emergency room or treating the emergency room as your primary care provider. These things impact health disparities. If you don't know that you have diabetes, if you've never gone for your yearly checkup so that they could check to see if you would have diabetes, then if you come and it's so uncontrolled, it's going to have all this impact on your health overall, on other functions of your body, because diabetes can just start, kidneys, liver, all of that. So, so it just is one of those things where the healthcare system that we have encourages the disparities that we have in this country. If we had a equal payment plan, an equal treatment of all groups, of all communities, it would decrease health disparities. And I do know from frustration of a lot of my friends, a lot of people that I know, family members, have expressed very big, just huge frustration with especially Medicare, because a lot of those, especially our older population, often in the doctor's office, often having to go to the emergency room, and they're always talking about why is this system not working? Well, it's not working because there's so much of a focus on insurance companies.
Yeah. I
And
think this is a great segue to go into Dr. Sanjeev and let him talk a little bit more about Medicare for All and the policy and everything like that. Dr. Sanjeev?
Yeah, hi everyone. So why don't we talk a little bit about what the specifics of the legislation, how the policy actually works? Because I think Medicare for All has been kind of thrown about as like this football, and it's been made to sound like a lot of things that it could be, that it might not be. And so it helps to sort of just bring everyone to the same place of policy about what does this actually do? How does it work? So right now there is a Senate bill that Bernie Sanders introduced in 2017, and there is a House bill that Congresswoman Pramila Jayapal introduced back in the beginning of, in the end of February 2019. Congresswoman Jayapal's bill, since that introduction, has gathered a lot of momentum among House Democrats. Pre-pandemic, there were over half of the House Democrat caucus was showing some kind of support for the bill. They were co-sponsors for the Medicare for All bill. There have always been rumblings that there could probably be more Democrats who are interested in the bill, people who were curious but not committed. And since the pandemic started, a lot of the rumors are that there are even more people interested in how does this bill work. So let's get into it a little bit. First off is that we have to talk about universality in a very different way. When we talk about universal coverage under Medicare for All, we're talking about covering every US resident. This is different than covering every US citizen. This is covering every person who lives in the United States. This is a much more racially just expansion of healthcare because we are finally acknowledging and recognizing the humanity of our undocumented brethren out there who have for too long been cut out of the American healthcare system, despite the fact that their money keeps going into it, but they're not getting a whole lot of coverage or care from it. So it's an important distinction that we're talking about covering every US resident, everybody who lives in the United States. Then both bills, the Senate bill and the House bill, have a lot to do with the transitioning of people who get their care right now from Medicare, Medicaid, the Children's Health Insurance Program, the Federal Employee Health Benefit Program, and finally, yes, employer-sponsored insurance. We're going to be transitioning everyone into Medicare for All. The VA and Indian Health Services will continue to function independently. And after X number of years, some people say 5, some people say 10, but after a certain amount of time, once Medicare for All has gotten its legs, there will be a time for the VA and the Indian Health Services to decide whether they want to continue as independent entities or if they want to be part of Medicare for All as well. Now, this transition of getting everybody who is in Medicare, Medicaid, CHIP, the Federal Employee Health Benefit Program, employer-sponsored insurance, the transition of getting all these groups of people into Medicare for All does take some time. It is not something that will happen overnight. It is not going to be that, you wake up one morning and everyone is on Medicare for All. There is a transition period in place. The House bill, it's 2 years. Bernie Sanders bill, it's 4 years. What the transitions have in common is that in year one, kids, everybody under the age of 19 and everybody over the age of 55 get covered in Medicare. And then everyone else has a slightly longer or shorter transition period, depending on whether you're looking at the House or Senate bill. Now, when we talk about Medicare for All, we do have to recognize that we're not talking about the Medicare as it currently exists. There are a lot of things that Medicare right now does not cover, such as dental, vision, hearing, prescription drugs, durable medical equipment. Like if you need a wheelchair or even a cane, Medicare doesn't help you with a lot of that. Long-term services and supports that let you live in your home or in your own community. Again, Medicare doesn't do that. A lot of states have very different ways of covering that with their Medicaid programs. And with Medicare for All, we're finally resolving that. We're finally saying it does not matter what state you live in, you're going to get long-term services. It doesn't matter what state you live in, you're going to get your dental, vision, and hearing taken care of. And this is in addition to all the things that we've been getting, the essential benefits that the Affordable Care Act was covering, such as rehabilitative services, like that's your physical therapy, your occupational therapy, speech therapy, lab services, preventive services, outpatient visits, emergency room visits, inpatient hospitalizations, pediatric care. As a pediatrician, obviously, I'm biased about that one, and I'm glad to see it. But another important part that's going to be covered is reproductive care and women's health. For too long, reproductive health and women's health has always been sectioned off, and there's a whole other set of rules that apply to birth control, abortion. And with Medicare for All, what we do is that we simply say, you know what, all of that is healthcare. It's going to be part of healthcare the way that all of these other things are part of healthcare. And we're not going to create a completely different set of rules, a completely different obstacle course that our sisters have to go through just to get their basic rights in that healthcare area. Now, as far as which hospitals and doctors you're going to see, it's the exact same hospitals and doctors that you see now. Right now, you have doctors who are in the private sector, and you have doctors who are in the public sector, like in the county hospitals and other public institutions like state university institutions. And what you have is that all of these different doctors are paid by all of these different contracts, right? They're paid by this insurance contract with Aetna, this one with Humana. They've got, the state Medicaid, they've got Medicare, they've got all these different payers that they have to juggle. With this, we're talking about single payer. So there's only one person whom they have to send their bills to, they have to send their claims to. And it doesn't matter if that doctor is working in the private sector or in the public sector, they bill Medicare when it comes time to get reimbursed for the work that they're doing. And you as the patient, what that means is that welcome to the network that is everybody. It is not about trying to figure out, oh, this doctor down the street, they're so conveniently located. Ooh, but they're not in my network.
Yeah.
Same thing with this dentist. They're not in my network over here. And so when we actually bring all of these providers together, it reduces a huge amount of the disparities that we talk about, because we're finally able to get care in our own, in our own neighborhoods, in our own
Yes.
communities. The last thing I want to address is that, and I really want to make sure that we take the time to talk about it. And that is, how do we pay for it? Too often, Medicare for All activists are accused of dodging the question of how do you pay for it. And quite frankly, I want to say that there is a buffet of options that we can go through for taxing the uber rich. Right now, we just found out that Jeff Bezos is on his way to becoming a trillionaire. The man has become only richer during a pandemic. We've got Wall Street, Facebook, Silicon Valley, all of these different entities that have just been sitting on trillions and trillions of dollars. Yes, we will be taxing that in order to pay for healthcare. Right now, the way we pay for healthcare now is we don't have a system that's fully paid for. What we've got right now is fiscally irresponsible. It's fiscally irresponsible to the point of being fiscally stupid. And so, yes, I would much rather know that I'm going to have a piece of my paycheck taken out as a form of a tax, and know that I will go to any doctor, that the network is pretty much any doctor or dentist that I can find, that that when you take a piece out of my paycheck, when I show up to that doctor, when I show up to that hospital, there's not going to be some bill that comes creeping into my mailbox later, because it would have been knocked out. That's what you took from my tax is means no more premiums, no more copays, no more deductibles.
No more explanation of benefits.
Right. And
those right there.
And there's savings, right? I mean, it's $500 billion of savings in administrative work. When we don't pay the most in prescription drug prices, we save $300 billion. So to me, the big challenge of the money in Medicare for All is that when you have a system that saves $800 billion a year, how do we make sure that those savings get back to the communities that have been historically and for and systematically cut out of healthcare so that we can start lifting up our brethren and make this a system that works for all of our well-being.
Thank you so much. So we have our first question from the audience, and it seems as though people just want to know why things are the way they are. We have our Black and Brown communities. We're hearing all these health disparities. We know that your health outcomes are worse. You're dying in larger numbers. How did we get here? And I'd like to just start with Sergio on this question. How did we get here?
Yeah, I mean, we were founded with these principles as a country, and we haven't addressed it. It's like the crudest but still factual take on it. You know, we were founded out of the sense of it's about it's exploiting people for a minority and ensuring that exploitation so as to build profit. Our healthcare system is a reflection of that. It's an explicit continuation of that.
Yeah.
Until we actively talk about that explicitly, that is how we get to Medicare for all. And that, because by doing so, we're talking about we need a radical transformation of societal values. Not in a way that's actually radical, but just to keep up with the rest of the modern world, which has understood that there are fundamental human rights for every single individual in their countries, and that understand that one of the benefits, not the responsibility, but one of the benefits of living in a wealthy industrialized nation is that we can collectively afford universal health care, which improves outcomes for the entire society.
Yeah.
But to do that, we need to, we frankly, we need to survive what the moment that we're in right now, and do that by building explicit cross-racial coalition building and talking about why we deserve, why we've been owed, Medicare for all and so many other restitutions. And how that is actually really, these should be seen as like not as big asks, but as fun, like foundations that are needed for our society to actually survive at this point.
I want to jump in here because I do.
Definitely wanted you to jump in.
The discussion needs to talk about what has changed over time. The change, we always talk about how at one point there was a closer ratio between the average salaries of like regular middle-class Americans. And of course, there's always been the disparities with Black and Brown communities, especially African-American communities over time. But there's also a trend, and we talk about like the CEO salaries. We talk about that, and that's been a big discussion of how from the 70s things changed and that it went from a smaller percentage to a larger percentage. Well, if you actually look at that, that start of the 60s, 70s till now, that has been the drastic increase in healthcare coverage. Why? Because of greed. Companies got together, just like banks started getting together, insurance companies got together, they started to link, they started to see how they can take advantage of the process, prescription, even we talk about just sort of the pharma company, the pharma industry and how they started taking advantage of it. So everyone jumped in, and while Medicare was building, where we're talking about legislation from 1960s, they were more focused on low income. These other groups were focused on how do we make more money. And over time, this got to be the point where increases in coverage, everybody now, they said now, at one point in the 50s, 60s prior to, independent hospitals were everywhere. And so was doctors had doctors in many communities, they had doctors in communities providing direct care. But over time, a doctor in a community could no longer really afford to play in. So they had to affiliate themselves with hospitals. Over time, single small hospitals could not survive because they could not survive negotiating with insurance companies. They could not survive and suppliers, everything. So now we're getting to the point that if you look at every hospital around you, it's in a system. Look around you, in every hospital, it's in a system. So therefore, if you don't really have the opportunity to start shopping around anymore, because you've got your systems, and you got to pick the system that you're with, and that system is negotiating with the healthcare insurance company to get whatever they can get so that they can provide more care in the way that they want to. And then where does that leave the consumer?
Right.
So
Yeah.
this is a whole
Where
system.
does it leave the doctors and the consumers? I've had a doctor tell me that she got a check from an insurance company for 1 penny that they
Yeah.
mailed to her U.S.
Right.
Postal Service.
Right.
So,
And I mean, and it's interesting that you bring that up, right? Because I mean, like when doctors, I think that when you look at how physicians are paid, it's such a hustle from the insurance companies. I mean, they try to manipulate, and they've done a brilliant job of marketing this to physicians that, oh, if you take, Medicaid, you're a sucker. Medicare doesn't pay a whole lot more than Medicaid. And, but if you go with the insurance will pay, if for every 60 cents that Medicare pays you, the private insurance company is going to pay you $1.10. But what they don't tell you is that 50 cents gap, like that extra 50 cents, is going to cost you in time. You're going to have to hire someone to get on the phone, argue with them, talk about, when you find, and all of that time, it's like 3 weeks.
taking away from the patient.
It's 3 weeks
taking away from the patient, and it's also taking away from the community, because the community is what needs the care, and we're worried about administrative cost.
Right.
So I want to move on to the next question. We have a question for Dr. Charles. We talk about, oh, did you want to comment?
I just wanted to give a little historical perspective, because there was a time when the hospitals were run by physicians. And so that code of ethics is very different from an accountant or an MBA, because they did not take an oath. Their oath is to make a profit for whoever they work for. So those hospitals took care of patients, but they were not run in a financially feasible way. And eventually physicians were moved out of those leadership positions and replaced with MBAs and accountants and business people who have whose allegiance is not to patients, not to healthcare. It's about profitability.
I've even heard top executives talk about how it's not good to have a doctor in charge because they do not understand the system. So it's getting to the point now that having that, even the top people kind of think like a doctor in charge is like, and now they're even telling people that if you want to get like MBAs, things like that, that's more marketable for them. And maybe if you get a little degree on the side for health to kind of make yourself more marketable, it's almost like a formality. So you're seeing like a lot of the executives, when we look at their records, we find that they might have an MPH, or they might even have an MD, but they've never actually done any practice, because the point of practice, it's about background in business.
Yeah.
So
I actually have a point as well. I've been doing a lot of research on the history of this, and our hospitals started out segregated only for white people. Our doctors for the women that were enslaved were veterinarians, and for the men that were enslaved were veterinarians. They weren't MDs. And then once we got out of slavery and went into American society, we were still treated as if we weren't worthy of the care. So even if you had the first Civil Rights Act of 1875, they overturned it in 1884, and we don't get care again in a hospital in the same facilities and the same resources until 1964 with the Civil Rights Act. And in that Civil Rights Act, the only reason they integrated the hospitals and stopped making you go in through the back door is because of Medicare.
Right.
It was a rule in Medicare that you could not be segregated. Right. If you took on Medicare, you could not be segregated and you could get this money. So the whole profit motive for them to desegregate their hospitals is to get money.
Right.
And if you accept more patients, if you accept everybody and you have everybody under one system, the hospitals can be paid for, but we won't be paying for is all these insurance companies and their
Right.
quirky commercials and all their
Right.
administrative fees. So
Right.
that's why this is important. If we make Medicare for all a priority and improve Medicare for all where everyone is covered, it is basically doing the same thing we were trying to do in the beginning,
Yeah.
but for everybody. So I just wanted to point on that, hit that point as well, because
Yeah.
I feel like that's really one of the reasons of why we get here. It's one of the reasons of why things are the way they are.
Right.
So I wanted to hit
gonna-
on that. And did somebody have something?
Yeah, Keisha,
I
that
forgot about the
history.
question the caller,
Oh.
a watcher, a viewer had. I don't want the people that we.
Yeah, we have a question right here for you, Dr. Charles.
Oh.
We talk about many of the illnesses that plague the Black and Brown community as genetic. Is this true, or does racial disparity play a role?
It is multifactorial. There are studies that have shown that diabetes can be reversed. Diet has a tremendous amount of influence in the diabetes in our community. The food deserts, the dependence on carbs, on animal products, high calorie but low nutritional value foods, the lack of exercise, the lack of fresh fruits and vegetables, where you can get a meal for $1, but if you want a bag of apples, it costs 5 or 6.
Mhm.
It is that makes a significant has a significant influence on these chronic illnesses, but our ability to make targeted choices in our diet and our lifestyle can override, in many cases, the genetic predisposition to diseases that we may have. So definitely, we have the power to change our healthcare status.
Do you think that people know that? Or is that just, my mom had it, my grandmom had it, my grandmother had it, great-great-grandma had it? Is that mean now I don't have to? Or do people realize that they have that option? Are they able to afford that option if it's a matter of money?
I think, no, I think most people don't know that. I think that most doctors don't have the time in their visit to have that conversation. When I was in medical school in the late 90s, the average doctor's visit was 45 minutes, sometimes an hour. Now the average visit is, around 15 minutes. So there's not a lot that can be covered in that time. But the information is out there. It's one of the reasons why I have become a life coach in addition, so that I can talk to people about their food choices and help people be empowered by the knowledge. When I have the opportunity in a room with a patient, I certainly give that information. I give them literature so that they can make an informed choice. Now, they may choose to eat what they want to eat, but they are aware of the potential consequences down the line. But at least they have the information and they can make an informed choice. And I tell them about, there are companies out there that deliver organic food to your door, and it's they call it the ugly food. So it's a red pepper, but it's not all red, it's not all green. Or maybe it's not even deformed, because I've gotten it. It was $35. It was 25 pounds. I could not lift that box, delivered to my door, and it was organic.
Nice.
So
So the options are there, But what about epigenetics? What about my mother suffered stress, or my great grandmother suffered stress, and that stress is passed down to me, and then the community, the stress of the community, the stress of the job, the stress of even just having this pandemic
Absolutely.
affecting my genes and affecting my ability to even fight off disease. What about that?
Epigenetics is a fairly kind of a new topic. It's been around for a few decades, but it's getting more and more notoriety and more information. More people are talking about the fact that these stressors can affect your DNA. And we're talking about historical traumas that have been imposed on Native American populations, and it
Mm,
goes from generation to generation to generation, and as well as Black populations, brown populations. These traumas affect the genes, and because you are dealing with stress, the cortisol, or stress hormone, is released, and that affects the baby. The fetus is bathed in those stress hormones, and then that child is now affected by things that happened many generations ago, and we're all dealing with that. And so that is an area that is very hot and is really being studied.
So
You know,
let
one of the things that I wanted to point out about, about these stresses, though, right, is that as much as we're talking about, biological mechanisms, the stress is a policy mechanism, right? Like,
mm,
like poverty is not biological. Poverty and oppression are not biological. Those are human choices that humans did to other humans, that people
mhm,
do to other people. Like, the stresses that we're talking about did not originate from anything biological. Even COVID-19, the pandemic, like pandemics are policy failures. They are not biology failures. Like, there is nothing about the biology of Black, Latinx, or Indigenous people that make them 2 to 3 times more likely to get infected and die from
hmm,
coronavirus. There is nothing about the biology of people of color that put them in this war path. It is economic systems, it is political systems, it is policy systems that mess people up and that have set people up for death and infection and death. I mean, if you look early on in the pandemic, right? Because I mean, only 1 out of every 5 Black workers can stay home. Only 1 out of every 6 Latinx workers can stay home. That was our number one defense against coronavirus, was staying home. And it was not available to the majority of Black and Latinx workers. So
mm,
now you have to leave your house. Now you're at risk. Secondly, you're at a job where your boss is completely unclear about whether you should be wearing a mask or not, whether you should be social distancing or not. Earlier on in this pandemic, there were bosses telling workers, do not put on a mask. It is scaring away customers. It is freaking them out. This is not that big a deal. You don't need a mask. We're not providing masks. You don't need to wear a mask. We don't want to see masks around here. So now you, as a worker, again, you must work, right? Like, you're not getting any universal basic income. There's no economic support coming in policy wise. So you're out of the house, you're working at a workplace that is unclear about, how to protect yourself, doing what work that is considered essential while you are being treated like you're expendable,
yeah,
you know then there are benefits. Good luck whether you might be working at a job for 3-4 years and still be categorized as temporary. What we there are plenty of things that, like, the insurance companies, large employers, learned to hack in Obamacare. They learned that, oh, so if I'm required to provide health insurance for people who are working 30 hours a week, so I just need to make sure everybody's working 29 hours a week and I don't have to provide them health care, right? So let's try to, just finagle the schedule so
mm,
that people, and whenever they want to ask for overtime or something, we say no, or we kind of manipulate it, make it work out so that those extra hours don't happen in this month, and so that the math never works out that I, as the boss, have to provide the worker with health benefits, right?
Yeah. And I want
And
to
and
keeps
Walla
going.
did
It
wanna
keeps
jump in
going.
here. Let Walla jump in here.
you kind of get irritated when everything is about, oh, maybe it's because of your genetics, maybe it's that, even though those things do play a factor. Let's just be honest, these numbers that show 20 or 30% African American and Hispanic communities having bigger numbers in chronic diseases than white community is not genetics. It is simply the economic factors, but not only that, the healthcare system we have, our healthcare system does not benefit by you eating apples so you don't have to go to the doctor. They benefit
Right.
you going into the, especially if you're in a place with fee for service, they benefit from you coming in constantly. They don't encourage you, they don't push you to sort of do things to do preventive care. Why? Because if you go to the hospital with a very a chronic disease that has you in the bed for 3-4 days, they get paid for that. They don't get paid if you just talk to your doctor over the phone and the doctor says, Dr. Charles says, here's how you reverse your diabetes, because you need to be on that medication, diabetes medication, so that a prescription, a pharma company gets paid, and so that a doctor gets paid, so that you can constantly keep getting the labs and tests and also seeing the doctor so that they can keep monitoring you over time. So I'm just saying, like, it is one of those things where our system does not encourage it. If you go to certain communities,
Would Medicare for all, would improve Medicare for all that Dr. Sanjeev explained, encourage preventative medicine?
yes, I mean, I've seen it, and I know nobody wants to talk about other countries, but it does work better in a lot of those countries. If you are in a place where they have doctors everywhere, they constantly go to the doctor, whether they're in a poor community or wealthy community, they have relationships with their doctors. The truth is that is not in the communities that we have now. A lot of people don't take Medicaid. A lot of people don't want to deal with Medicare. A lot of, to be honest, I've worked with people in Southeast and certain part of the community, even in Capitol Heights, they say they don't have transportation. So the reality is that I don't want to keep going to the doctor all the time. The lady said, because I got to take 3 buses to get there. Or I want to go across town because I don't want to go to my local hospital because it doesn't have the services I need. So I'm going to go across town, and that takes 4 or 5 buses and a transfer and $4 I don't have. So that's the reality in a lot of communities. People cannot afford to have doctors. They cannot afford all these copays. For some people, $20, $30 or copay doesn't matter to them. But some folks, they can't, like $20, $30 is the difference between.
Right.
And the co-pays now are, well, in my case, the co-pays now are not even co-pays. It's 100%
Right.
of the cost of going to the doctor.
Right.
And a 15-minute appointment that I had in January cost, I didn't know what it was going to cost me,
Right.
but I got a bill
Right.
for $400.
Right. I mean, and
And
let's
it's
be
like,
real, right? Like that.
these kind of things, I think, are really just keep it scaring you from going to the doctor.
Yeah.
Because I think, Sanjeev, you've said before, a copay is a penalty.
I mean, a copay is a penalty. A copay is a box of organic food, right? Like, I mean, it's like, welcome to, like, okay, like, why don't you have $30 for healthier groceries? I gave it to the doctor's office for a whole lot of nothing. It's, and to Walla's point about, like, hospitals in the community that don't provide the services that the community needs, that is a capitalist failure. That is because those hospitals are listening to a bunch of private equity people telling them, oh, you don't need to go and have better prenatal care, which would actually, like, improve birth outcomes for all of these Black infants. What you need is a new MRI suite. You get a new MRI suite, and that's going to be something you can market, and no.
Wow.
And it's like, that isn't healthcare. Like, like like protecting the lives of Black babies is not profitable. It is moral, but it is
Yeah.
not profitable, right?
I heard a statistic recently that Black babies delivered by white doctors die at like twice the rate than a Black baby delivered by a African American doctor.
Right.
When it comes to stuff like that and better health outcomes, when your doctor looks like you and your
Right.
child can survive because your doctor looks like you, how would something like, how is that affecting our COVID rates? And
Right.
how is that affecting everything as well?
So I'm glad that you're bringing up this point, because it actually does point out something critical about Medicare for All. Medicare for All does not end all racism in healthcare. right? Like there is a ton of racism that is a major obstacle to why we don't have more Black doctors and why we don't have more Latinx doctors. I mean, Black doctors only make up 3% of America's doctors, despite the fact that, you know, I mean, they're 15% of the population. I mean, so, and Medicare for All doesn't necessarily like, you know, like, I mean, attack that and go after it. Similarly, you know, Medicare for All won't work in a food desert. Medicare for All won't work where there's pervasive homelessness or risk of homelessness. You know, Medicare for All doesn't work when there are poverty wages. Like it has to be part of a fabric of racially just and equitable minded policies that are about lifting up people in every element of their life, you know, in their, at their job, at the home, in the school, so that like we're actually looking at these things as true human rights. We're not trying to, you know, determine, are you eligible for housing because of all of these different criteria? No, you're eligible because you are human. That is what Medicare for All is. That's what we need a lot of these systems to be about. And, you know, like a lot of what we're talking about right now, like, I mean, Medicare for All simply will not lift up everyone's health if it's still that we're going to just let, you know, like klepto capitalism like wreck people's lives so that they keep going home to poverty. You know, like Medicare for All won't be the answer to that. Like it will do a lot. It will make it so that like, you know, you don't, I mean, you're not second guessing, you know, can I afford to go to the doctor, or do I need to get my groceries, or do I need to get my kid back to school supplies? Ooh, because you're damned no matter what decision you make on that one, right? Medicare for All ends that false choice, but we need systems that actually complement Medicare for All to lift people up.
Right, but let's just note now, and I agree with you, it doesn't solve all the problems, but it does solve some problems because as I said before, most, you know, Medicare and Medicaid has the lowest payment, and many people complain about it because we're not fully investing in it because we do have health insurance playing in a part. If you remove them, that gives us the ability to improve Medicare and Medicaid, which would allow in Black and Brown communities, we do have, like I said, 40 to 50% of the people of the population has Medicare and Medicaid. But let me just tell you, doctors in those communities complain that they cannot survive off of Medicare and Medicaid. So the way that they make it is that they pound their day 15 minutes, 15 minutes, 15 minutes, 15 minutes, 15 minutes, 15 minutes, because that is the way that they are able to bill. If you have so many people,
Yeah, it's
Yeah.
profit motive.
Yeah.
Everything is profit motive.
to kind of that. And those quick, as Dr. Charles pointed out, those 15 minutes are you're not able to really do full care, but that's what is allowed in the community. I know too many doctors in Black and Brown communities that cry that they don't make a whole lot of money, like people assume doctors make. So a lot of them do go into the hospital system because it's salaried and they don't have to worry about the risk of maybe losing their practice. And I don't know, sir.
Adrian, have you seen, Dr. Charles, have you seen that as well in your experience where doctors are saying, I'm not making the money I should be making because of where I work?
I would say, see, I finished med school in 98. And in my class, I know most of us chose not to have a practice because our attendings, they worked all these hours. They never went home. They couldn't take a vacation. Somebody else had to cover. They're calling around. And when you're trying to balance that, get that life work balance, I think the pendulum has swung where folks, new physicians, were looking at having a life and taking care of their patients and move towards being an employee. And now, once you're an employee, you now don't have the autonomy to talk to your patients, which is the downside. Yes, you know you're going to have a steady paycheck and you can pay off your student loan. Great. But now you have a 15-minute visit, or the patient has a 15-minute visit, and that patient has no idea that that 15 minutes starts once the medical assistant calls them from the lobby, puts them on the scale, does their blood pressure, asks them about, you know, do you smoke, do you drink, and that whole social history piece that can take 5-10 minutes. So now I come in, I don't have that 15 minutes has been eaten into. And that 15 minutes includes me trying to get to the heart of why they're here, because I know time is short, but the patient has no idea. So you're trying to do it within the time, but not make the patient feel rushed. But that's the process that you work in. And then
Are these imposed by your employer? Are they telling you you have 15 minutes for everything?
well, you have a schedule.
Right.
So you have a
Oh,
3 o'clock
God.
patient, you have a 3:15
Right.
patient, you have a 3:30 patient. So no one's telling you you've got a schedule.
Right. Right. I mean, and you're getting
Patients
pinged.
don't understand that they can't come in with 5 things. You don't have time for 5
Right.
things. So
Right.
like,
Yeah.
what is the one thing you want to deal with today? And you try to do that. Now, if it's a slow day, it's raining and people don't come in, you can start talking about making healthier lifestyle choices, getting the weight down, little tweaks. Have hibiscus tea for your blood pressure 3 times a day. That brings blood pressure down. Add cinnamon, that helps with blood sugar. You can start to do that. But if you're on that treadmill, you just don't have the ability, the luxury.
This explains so much about why I don't like going into the doctor's office.
Yeah.
This explains so much. I did my first video doctor call, and I had a whole 30 minutes to talk, and it was just so refreshing to actually get information.
Yeah.
And I think that that's one of the things that's lacking is information. Sergio, in your experience, have you seen that your community is lacking information about how to actually deal with the health issues of your community?
Yeah, I think that's just kind of universal. I unquestionably within the Latinx community, but more broadly, as other panelists had already mentioned, the reason why is because there's no incentive for it. If we have a chronic care system, not a healthcare system, because chronic care is a lot more profitable, and so they're and don't get me wrong, I know for a fact that doctors are going out of their way, as Dr. Charles was talking about, to try to make the most of what time they have to get to that point. But the broader structure doesn't, as she was mentioning as well, it's been reduced over time explicitly out of a sense for figuring out where you can carve out more money. So the incentive is, it's frankly diabolical. Like, the incentive is to basically make sure you have enough information to come back. That's not at all the incentive that doctors carry. That's not at all, I want to make that clear. That's not how nurses, assistant staff, everyone in hospitals day to day, they're not thinking with that mindset. But the structure, is over time, just that's what it inherently promotes, because there isn't an incentive to thinking about how it's not about cutting costs. It's about improving long-term outcomes for individuals and communities. And so that mindset isn't allowed to embed itself within a for-profit structure. It actually goes whenever people fight to get it in there. It only lasts but for so long, because we do not have an explicit healthcare system that sees healthcare for what it is, a fundamental human right.
Great. I
And
think that's, is there anything else?
The electronic medical record system that is required based on the Affordable Care Act, which we were told would be a vehicle to make healthcare more streamlined. So, but that's not what it's done. Now it takes more time. You see the patient and you have to enter this information into this silo that each system, where there are at least 5 or 6 different electronic medical record systems that are sold, and they don't share information with each other. So maybe you were with this hospital system that uses electronic medical system A, but now your insurance has changed because of money and you're at somewhere else. But that information, they don't talk to each other. And it's not useful to the physician or the nurse practitioner, because I have always said, well, why can't we? You've got all this information in here. Look at everybody who needs colon cancer screening. Write a list, get all that information down, call those people and follow up. Who's due for their PAP? Who needs a flu shot? Use that electronic medical record system for healthcare. But that record system is for two things: getting paid on time. You put that information, because that's part of the 15-minute visit. You got to do your note and finish up your billing by the end of the day.
Right.
So that's sent out to the insurance company. So getting paid, and also data, so larger corporations or larger medical university complexes can do research and then get more income.
Right. And so that's actually, I mean, I'm so glad that Dr. Charles brought this up, because when it comes to Medicare for All, when we talk about $500 billion a year going to administrative nonsense that does not make anybody healthier, right? To me, the big challenge of Medicare for All is not how do you pay for it. It's, again, like when we save $500 billion from administrative waste, when you save $300 billion from not paying for the most in prescription drugs, how do you take all of those savings and reinvest it in a just way, so that we're doing exactly the kind of things that Dr. Charles is talking about, where our electronic healthcare system, our record system, is not just a billing machine, but it's actually, like, contributing to how I and my patient work together on health together. And that, like, and if Dr. Charles and I are in a practice together, how do we look at the community of patients that we're taking together, and we start to kind of figure out, oh, this is what our practice needs to be doing differently, or this is what our hospital should be investing in, right? Like, there's so much that those resources need to go towards. And I think, like, the challenge of Medicare for All is that when you stop putting money into the pockets of profiteers and you start putting money back into people, it is hard work, and there's a lot of challenges there to make sure that it's done right, that it's done equitably, and that racial justice is a cornerstone of that.
Yeah.
And I welcome those challenges, because I look forward to that work. I don't look forward to being an insurance company busy man anymore.
Interesting. An insurance company busy man. I've never heard it put that way before. All right, I want to just ask you guys one more question before we close out. And I really am interested in getting to know you guys a little bit. I'd like to know, before we close out, what was it that you saw that made you, or that you saw or heard or experienced, that made you get into this work of activism and working towards racial justice with healthcare? I'll start with Sanjeev, since you just talked.
Okay. Oh, sure. So, my involvement with Medicare for All is deeply rooted in racial equity, simply because living in Maryland, we're the first state on the East Coast to become a majority people of color state. And I mean, that just happened at the end of 2018, 2019. We tipped the scales, and we are just slightly over 50% a majority people of color. And so the rest of the country is supposed to get there by 2040, but Maryland, we're already there. Where I grew up, California has been there for a while. And to me, I feel that healthcare has to be a critical part of who we are. This has to be baked into our identities moving forward, if we're going to be the kind of just society that cherishes each other and wants equity and justice to be values that we live upon, not just talk about.
Awesome. I didn't know about that statistic. So I'm a majority now.
That's right.
I'm okay. That's good to know. Change how I walk around. Wala?
Yeah, I would say for me, Medicare for All really became more of an issue. It was single pay at that time. When I actually, I went to an emergency room at 18 years old because I had a allergic reaction, and I was told by Washington Hospital that I did not have insurance. I was kind of confused because I've been going to the doctor for years. Come to find out that I was on Medicaid, and Medicaid kicks you off at 18 when you're and so I didn't have any health insurance. I was in college, and the college health insurance that I had only covered a short part of the visit. So I got a $3,000 bill that went on my credit. And my parents are not wealthy. My parents are immigrants. They don't have $3,000. Nobody in my family has $3,000 to pay anything. I eventually, after some years, were able to get it off my credit, but that freaked me out. And that got me to the point that I was scared actually to go to the emergency room. I did not go to the doctor in college because of, if you went to the student health place, if you went there, that was covered. But if you went anywhere else, it was not covered. Even, so all through my life, I found that I even have an eye condition that was covered when I was in the federal government. When I left the federal government, it's not covered. So it's things like that that got me really worked up, because I myself have to think about what's going on. But more so, as being a labor lawyer also, the hardest thing is having to sit down. I mean, it's like maybe 6 months ago, I sat down with a nurse and had to tell her that she was 61 years old. So she's about to get laid off. And I had to explain to her that she would not have health care. So we had to talk about how she was going to do that, because she was not old enough to get on Medicare. So she's like, well, what am I going to do, Walla? And I have to explain to her that either way, we're going to try to find you to get another position here. She was like, well, what am I going to do with healthcare? Because she had all these medical issues. And I just sat there and I was like, I don't know. I don't know what you can do. Maybe you can look at this. We looked at the COBRA, and she was required to pay $600 a month
to not even go to the doctor.
So she says, well, you know what, Walla, I'm not going to go to the doctor between now and 65. I'm telling a 61-year-old woman that she cannot go to the doctor between 61 to 65 years old, because she's not going to have healthcare coverage unless she's willing, when she's unemployed, to pay $600 a month. So
and that's not including her copays and deductibles. That's $650 to not go to the doctor.
Right. So that's the thing, is that's what it's covering. But even more so, recently we were fighting for a United Medical Center in DC. And that's really when it opened my eyes about the whole system and how it even impacts low income communities, and having doctors in the community say, well, I can't do my practice in Southeast because I can't get paid. You know what I mean? Like, I have to kind of like, I can only do because I can't do, or having a doctor call me crying because at this point she has to fight with the insurance companies to get paid, because they don't have the incentive to really make sure that the doctor gets what they want. They're more, they're probably not going to fight a hospital like they're going to, like little old doctor here, she's back and forth with them, maybe threatening lawsuits so she can get her money. And she says she doesn't have a person that's working at her front desk they're doing what they can. So my point is, like, we have a whole system here. United Medical Center is a hospital now that's going to be closing. Why is it closing? Because there was no resources in it, but also because, frankly, they're competing with GW, they're competing with Georgetown, they're competing with Sibley, they're competing with all these places that have bigger and better names, and nobody is, so of course they're not going to give them the money that they need for whatever service that they have. Sometimes they say the hospital doesn't even get paid. They don't care about them. They care about the system. And that's when, even with Howard, you notice Howard joined Adventist. Now you're going to have a new hospital that's now joined the GW. Why? Because no hospital can stand alone anymore. And that was one of the people told me off the record. They said, you can't repeat this. No hospital is going to stand alone. If you're standing alone, you're going to die, because this system here, everything is made so everyone would join a system, because the system can negotiate and everybody makes more money. The same people have sat in rooms and told me that healthcare providers are not savvy in running hospitals because they don't understand money.
Right. So we still need to get to the last two before we run out of time. Yeah. Adrienne, what was your personal experience?
I didn't have a personal experience. When I got into med school, my goal before med school, I studied Ayurvedic medicine. I studied Chinese medicine. And what I wanted to do, had it existed, was a residency in alternative medicine. Now they have some hybrid programs, but that was my goal. Um, and I think working in with the military, working in DC Department of Health, working with on Indian reservations in South Dakota um, and in Alabama gave me a very broad view, and Medicare for All just resonates with me. So I haven't had any personal experience, but I just know it's right. And I have even said to patients, I challenge you. I want you to put me out of business. Don't I make me unemployed by being healthy, and then we talk about it. So I would love to see health for all, healthcare for all, but health for everybody.
Health for everybody. That's very, very powerful. I would love to see that too.
And stop the Chipotleization of medicine.
Yeah. I mean, I feel like I'm just body parts sometimes when I go into a doctor because that's all they can focus on is one part at a time. Sergio, I would really love to hear your experience of how you ended up doing activism because you're so active. I mean, we've been working together for years, so yeah.
Uh, yeah, I'm not exactly sure, but like more and more as I keep thinking about it, just my childhood comes to mind, where it, I just was able to learn a lot from living in different cultures at a very young age. So I lived in California, in Linwood, California, until the Rodney King riots, and then after that, my father moved my brother and I to Guatemala, and because he thought that it'd be safer to go there, and with the money that he was making working two jobs, he would be able to give us a decent private education in Guatemala. And so then moving there, I saw going from like living very much as poor immigrants in California to middle class, light skinned people in Guatemala. The stark contrast was such that it was so through a child's eyes in particular, just so obvious that there's no reason why I should be treated one way over another, outside of just this is how I live right now. So it just that got something going in me, and then when and then also my the reason why he moved is because my mother passed away from leukemia when I was 4 and my brother was 2. And one of the stories that my dad would tell us was just around how to be fair, they caught it pretty late, but one of the treatments that's now pretty standard, and has a very, very much higher survivability rate when you take this type of chemotherapy. She was working as a teller at Bank of America, and her insurance didn't cover it because it was considered experimental at that time in the 80s, and so she didn't get it, and so we lost her within a month. And so I know that it's not that it was just health insurance, but that the needlessness of like knowing that there's treatment there, but it just for some bureaucratic reason people get denied, really, really stuck with me. And then just saw how much fighting for universal health care is about fighting for the dignity of all of us, and pointing out that we have inherent worth and are worth as much as anyone who's rich or as anyone who's light skinned. And so, I really think that pushing for Medicare for all is one of several things that we need to do to push to regain our humanity, and see if our country still has a possibility of living up to its promise.
I'm so sorry to hear that about your mom, Sergio. If anything can get you moving, I think that is a very powerful story. I really think that after hearing these stories of how each of you came to come to this, I think that it's going to get more people active in the future. And more people ready to talk more, talk amongst your friends about what's going on today, about the racism, about healthcare, about all these things, and how do we make these disparities smaller? How do we erase these racial injustices that are going on right now? So with that, I would like to thank all of the speakers for coming, and I'd also like to thank our sponsors. So Christy, would you go ahead and put up the slide? These are our sponsors that came through for us and helped us with this event. So we'd like to thank you all. Casa Defensores La Cuenta, Flip, Healthcare is a Human Right, Lower Shore Progressive Caucus, Medicare for All Explained, National Coalition for Drug Legalization, Maryland Progressive Healthcare Coalition, which is the group that is running this, Our Revolution, Maryland, Our Revolution, Prince George's County, PG Changemakers, Prince George's County NAACP, Progressive Maryland, the girl with the pink wheelchair, and Council Member Tom Dernoga. So I'd like to thank all of you for co-sponsoring this event. With that, I would like to close out. Would anybody like to have any closing words, or are we good? We're good. All right, thank you so much. Thank you for all the people that participated, for all the questions, and we'll see you next time.
Thank you.
Thank you.